multiple drugs available, but the atropine 0.01% and off late the atropine 0.05% has also taken up the league with respect to myopia progression prevention. So in contrast to what many people believe that it prevents the accommodation and the ciliary muscle, well, no, that's not the mechanism of the action. It basically acts on retina, the choroid, the sclera, overall affecting the dopamine as well as the choroidal thickness, and hence it reduces the axial length elongation, and choroid, it resists the elongation of the choroid and stabilizes the eye structure. So as Dr. Dominic has already been stressing this, these drugs have to be used only when a progression has been documented. So what is progression? Basically an increase in the spherical equivalent of about 0.5 diopter per year or an axial length prolongation of 0.2 millimeter per year. So the studies which were previously done was the first one being the ATOM 1 study, in which 1% versus the placebo was studied, but then the chances of rebound myopia, the photophobia, the accommodation led us to ATOM 2. And so what do we mean by ATOM 2? There was basically the 0.5, 0.1 and 0.01% were studied, and they reached a conclusion that over a period of 2 years, 0.01% has the least rebound effect, least side effects and the least amount of progression. So any child who presents to us with progression of myopia, thorough cycloplegic refraction and axial length documentation, so we start them with the 0.01% atropine, and then you need to check refraction, the cycloplegic refraction, every 6 months. So if the child remains stable, that is less than 0.5 diopter per year, so we need to continue it maybe up till 2 years or 15 years of age of the child, whichever comes later. But in case the child is still progressing despite the child being on atropine, this is when comes the second part, that is either we can shift the patient to the defocus segments or the hard segment which have been already spoken by the previous speaker, or you can shift the child from 0.01% once a day in the night to twice a day, or maybe shift it to a higher concentration, which is the new vogue of atropine, that is the 0.05% atropine. So when we talk about the 0.05% atropine, where is it preferred? So this is especially in case of non-responders, that is those children who have progressed more than 0.5 even after 1 year of treatment, or the rapid progressors, that is they have been progressing more than 1 diopter per year or more than 0.75 in the recently concluded study by the ARM by Dr. Saxena et al. So the first study on 0.05% basically happened as LAMP 1, the low dose atropine study, and they did recommend that 0.05% remained optimal concentration to prevent myopia progression over 3 years, and the same thing has been reinforced in the recently concluded study by Dr. Saxena et al., where they said that atropine 0.05% definitely demonstrated a superior efficacy over 0.01%, especially in children who were rapid progressors or who were non-responders. There have been studies of atropine 0.05% which have been studied over the ocular surface effects also by Zinn et al., and they've said whatever the ocular surface pathologies which have been produced by 0.05% atropine has basically remained temporary and has been the surface has come back to normal even after discontinuation of 0.05%. So then comes the question, this is a higher dosage, what happens to the pupil, what happens to the accommodation? Well, the ARM study has proven that about the pupil, maybe a 0.8 millimeter, the maximum change, and 2 diopter accommodation change, which has been the maximum changes as of till now, as with both maybe 0.01 and 0.05% atropine. But then no matter what atropine we start, it has to be never stopped maybe at a bang when the child reaches 15 years of age. So it's basically has to be tapered. It is something like our steroids. So we alternate taper. The protocol that I use basically is I make it alternate day for 3 months and then I reassess the child. If it's stable, then maybe every 3 months we reduce it, taper it slowly, and keep evaluating for the progression both with respect to axial length as well as the cycloplegic refraction, and then keep on continuing tapering it. But if you feel that on tapering the child again recurs back and the progression comes back, that is when we need to again restart the atropine and continue till the child maybe stops progression. But then ruling out pathological myopia becomes very important, because that is something where the mechanism itself is different, and that is not maybe something which can be controlled by any of these measures. So with this, I would like to conclude by saying that maybe with atropine coming up for the myopia control, we can still say that a drop a day is trying to keep our myopia progression away. But no matter what said and done, as ma'am showed Dr. Dominic showed the mobile, a lifestyle change still plays a very important role in controlling myopia, whether you use DIMS glasses, whether we use Hall, DOT, Atropine, no matter which drug, the lifestyle adjustment, the parental counseling plays a very important role. So with this, I would like to conclude my study. Thank you.
Thank you very much, Dr. Joshi. Before having questions from you, I would like to ask Dr. Bremojuniak about the studies, about the which one of these technologies, because we know that there are different technologies, almost they are similar to each other with the same aim. But what do you think about the studies, scientific studies that are performed with these glasses?
Thank you very much for the question, because it's really very, very important. I think there is a lot of glasses just coming on the market and there is no studies. So for sure, if you prescribe your ophthalmologist, your optometrist, you need to prescribe a lens, a defocus lens that is that has a clinical research but strong one. So you need to have relevant clinical research with randomized studies, because if not, you don't know what you are prescribing. Can you imagine you go to the pharmacy and so you say, okay, I would like an antibiotic, but I'm not sure it works. So you can't do that. So you have children, and so this is very important. Thank you very much for asking.
Thank you. Are there any questions from the audience?
It's about the whole technology lenses. What's your experience with them? Because they're available in our market. And the second question, are the children tolerating these lenses? How long does it take for them to adapt?
I don't have a lot of experience with the new one, the 2.0, but for the first one, really there is quite no adaptation. They feel very, very well very quickly, and it works very well. So I really think it's interesting. For the 2.0, I don't know exactly, because the lenslet is double. So it could be maybe more difficult to be adapted, but I have not enough experience to say that, because it just came on the market just 1 month ago. Yeah, they can tolerate very quickly without any problem. The only point is, when you go to an adolescent like 15 years old, could be maybe a little longer. Just that. But children with 6 years old, they don't know. There's no problem, to my thinking.
Thank you.
Okay.
Yes, hi. So great talk. I have a practical question. What do you do? Do you prescribe these lenses if a child has strabismus or anisometropia?
That's a good answer. A good question. No, I never prescribe with strabismus, of course, and amblyopia too. So in this case, I think Dr. Joshi, she showed that atropine is much more adapted, because if you prescribe with a strabismus, of course, it will not be in the good condition. So that's for sure a good question too.
I had a patient, the mother was complaining about increasing strabismus after these glasses because the child had esotropia. It was well controlled.
So that's a contraindication for me.
Increase, and she refused to have it.
Yeah, I understand.
A question to both speakers. When both treatments are available, which one would you choose, or would you go for both?
So can I answer first? Okay, thank you. No, I tell you that it's customized, because you will have some children, they will never get the drops because they say yes, but after they don't get it. If you go to atropine, for instance, you need to be sure there is compliance, and there will be at least 3 years of eye drops, and so you must be sure of that. Instead of that, if you know that the child will not wear the glasses all the day, that's a problem too, but at least he needs that. So I think my first choice will be probably defocus glasses, because in France we have good health insurance, so it's quite easy to prescribe. And also because the child needs glasses. So that's why it's my first choice. But you need to discuss with the parents, and you need to discuss with the child. That's very important.
Dr. Dominic,
Yes.
just
So I
a
think
question.
someone is. So I think basically it's the customization in India. I need to see the financial status of the patient too. These defocal glasses and the hot glasses at a stretch put a lot of burden on the child's parents. So if they are not really affordable, that is one more thing I need to see. I start them on drops. But then there is second state which she mentioned, the compliance. A peripheral refraction is also mandatory in these children to find out what is the actual cause of which has been happening. So that again plays a one of the decision maker for us to decide what we are starting on. And the most important thing is the parent compliance. Despite all these things, if the parents are not compliant, I think none of our technology is going to work. So if the parents, there are some children having severe vernal keratoconjunctivitis and parents don't put the drop. So in those parents expecting that they would put atropine when they're not seeing any effect in the child, that we are seeing after 6 months. So that is something. So parental compliance, financial, peripheral refraction, all these three would totally, we sit over a many a times. I actually, children are eligible for both, and so many times I open it up as a platter to the parents to decide, because in we have that option in India, like, do you want this or this? Both work equally, but then you need to be compliant with the child's drops for the next 3 to 4 years. Here it's that the normal glasses what the child is wearing, instead of that he would be wearing these glasses, so they can take a call if the child is eligible for both of these.
Thank you, Deepti.
Sorry.
Is there like any advantage of combining both? I mean,
Yes, combination therapy is interesting, but you don't have to go to a big deal if you don't need it, because it's a double problem for the child wearing glasses and eye drops. But if they need, for sure, it's a good option, because the combination therapy has a bigger effect.
Dr. Dominic, just one question.
Sure.
Would you consider the use of this lens type of lenses in a patient who were treated with laser?
You mean laser
Myopic for ROP or something?
Well, in those cases, I think it doesn't work very well. You know why? Because when you have ROP, you are treating the the retinal periphery. So when you want to defocus, there is no more retina. And so the signal is not so good. So we try to do that, and I assure you it doesn't work very well, and it's not an adapted treatment.
Have you
for that.
tried before? Or?
I've tried, and I don't get good results.
Also, I've tried.
And you didn't get
failed.
good results too.
No.
Yeah, I understand that.
Thank
That's
you.
probably because the periphery of the retina is gone.
Dominic, what about the other one in the high myopia, like the one that you showed in Stickler
In
syndrome?
Stickler? Well, for instance, Stickler syndrome, it's different because they are minus 15 and then they have no progressive myopia. So in those cases, it doesn't work. I try also for retinal dystrophies, and some of them are may respond, but most of them they don't. But
Like congenital stationary night blindness, they have
some of them
myopia.
respond, but not all. For sure, it's not the best treatment. So it's interesting, of course, because we can try, because we have no other option. So that's why.
For the glasses, as far as I know, at least in my country, we have the insurance option. If there is an increase like 0.25 per year, they replace it. But it may not be the case for every country. Because they are expensive, they are making it for free for if there's an increase. And I think there's another question from Hiba.
Yeah,
Sorry.
we
sorry.
have that option as well. If there is progression of the power with the glasses that we have dispensed, they do replace it back if it's within 4 to 6 months.
46 months.
Yes.
Maybe not every
Yeah.
every
I have
company.
another question. It's a basic question. I'm not sure if I'm thinking right, but do you differ these rules and what we are adopting for the routine myopia? Does it hold good for children with ROP? Or should we have a different guidelines? Or I'm just giving it a thought.
That's
Because
just
it's totally different. The ROP
that's
post laser, post cryo, or injections. How do we follow up these children? or should it be similar to the regular myopia children?
Yeah, this is very difficult. You're right, because as I said, when you do laser or cryo, you are there is disruption of the retina in the periphery, and that's the periphery that gives the signal. So if you can't act on this, so that's why it's so difficult to get an answer with defocus glasses. Even with atropine, it doesn't work well if you are all right. So they are very difficult cases to treat, and I have no answer today. So
Because invariably
you.
they either they have
I'm so